We're going to give this a second try. I'm unmuting myself. The world of Zoom, we're all learning as we go. And I just want to say I'm so excited that we're able to accommodate this congressional briefing today. This will be the Maternal Mental Health Leadership Alliance's second congressional briefing dedicated to the mental health and wellness of pregnant and new moms. I'm thrilled that you're joining us for today's briefing. And again, we're focusing specifically on maternal mental health during this very trying time of the COVID-19 pandemic. Before we kick off the briefing, I want to address a few housekeeping issues. This webinar is being recorded and it will be available on social media platforms after the live feed. Talking points from the panelists will also be available, and there will be a Q&A session at the end. So there's a little chat button at the bottom of the Zoom, and you can submit those questions in the chat option. So I will say hello on behalf of myself. My name's Jamie Zalloway Belcito, and I am the founder of the Maternal Mental Health Leadership Alliance. Along with the March of Dimes, we are hosting today's briefing. I'm sure everyone has heard of the March of Dimes, as they have been a lead in association on the Hill for the health and wellness of moms and babies. But the Maternal Mental Health Leadership Alliance is new to this space. And we were founded, I'll just be very honest here in saying I myself suffered from maternal mental health challenges with both of my girls. And I was very, very distraught at the fact that as a middle-class white woman in the North Boston suburbs, I couldn't find any support systems. And it really made me think, what does that mean for everyone else out there? And I felt that it was incredibly important that I took my voice to the state legislature and federal legislature. And here we are, having partnered with March of Dimes on getting maternal mental health grants fully funded in Congress, and we continue to see the need for this, especially during this pandemic. Mental health issues like anxiety and depression are the most common complications of pregnancy and childbirth, affecting 1 in 5 women, or approximately 800,000 women every year in this country alone. Left untreated, these illnesses can have long-term negative impacts on the mom, the baby, and the entire family. And I myself found that to be true when I was in the depths of this very trying time, which is again why we're here today for our second congressional briefing for the Maternal Mental Health Leadership Alliance in conjunction with our amazing partner, March of Dimes. The cost part of untreated maternal mental health illnesses are approximately $32,000 annually per mother infant dyad, or 14.2 billion with a B dollars across the United States. These are some of the issues we will talk about today and that are available at the Maternal Mental Health Leadership Alliance website. I am excited to say that we have amazing co-sponsors today at the congressional level: the Black Maternal Health Caucus, led by Representatives Alma Adams and Lauren Underwood; the Congressional Mental Health Caucus, led by Representatives Grace Napolitano and John Katko, as well as the Congressional Caucus on Maternity Care, led by Representatives Roybal Allard and Herrera Butler. We also have amazing co-sponsors for today's event, and that's the American College of Obstetrics and Gynecologists, the American Psychological Association, 2020 Mom, and Postpartum International. I will now take a moment to say thank you to the Congressional Black Maternal Health Caucus, as we have a few words by the amazing Representative Lauren Underwood for today's briefing.
Hey everybody, on behalf of the Black Maternal Health Caucus, I wanted to join Congresswoman Adams and just saying welcome. I am so glad that you are having this really important convening. It's so important that we couldn't wait until we could be in person again. We know that maternal mental health has long been a problem, even before COVID. It was the source of many complications, a lot of deaths, and so now with the added stress and lack of access to care that is impacting so many moms across our communities, we know that we need to come together, identify some solutions, understand more about the scope of the problem. This work is so timely and so important. Thank you. Want to give an extra special thanks to the whole set of hosts. We have the Maternal Mental Health Leadership Alliance, the March of Dimes, 2020 Mom, American Psychological Association, ACOG, and the Postpartum Support International. Thank you for hosting this event. Looking forward to seeing you all soon. And please take good care of yourselves. Bye-bye.
Again, incredible leadership from fierce women warriors like Representative Underwood, who are aware of what these challenges are. As I had stated earlier, I, as a white middle-class woman, found challenges in this space, and now we are seeing what we've always known is that racial disparities are part of this, which is part of the conversation today. Without further ado, I'd like to introduce MMHLA board member and moderator extraordinaire, Dr. Terry Wright, who will be moderating today's event. Thank you so much, Dr. Wright. And we're going to have Dr. Wright do what I did, and that was unmute myself, because for whatever reasons, you have to press that little button.
There we go.
There you go.
Thank you, Jamie. Thank you very much for both. Good afternoon, everyone, and welcome to our congressional briefing. We're excited to be able to bring some really high-end speakers to this conversation to share some insight on maternal mental health, as well as what that looks like within COVID-19. So as Jamie pointed out, mental health conditions are the most common complications of pregnancy and childbirth, and fears of coronavirus have added significant stress and anxiety for pregnant women and new mothers. It's important to note that both mental health issues and coronavirus 19 disproportionately impact women who live in poverty, all women who live in poverty, and also women of color. Our speakers today will speak specifically about the intersection of maternal mental health and the pandemic. So just real briefly, today's panel includes 4 distinguished speakers. Dr. Kanika Harris, who will speak about her personal experience with maternal mental health. Dr. Rahul Gupta, who's the Chief Medical Officer at the March of Dimes. Dr. Pooja Lakshmi, who is a fellow board member with the Maternal Mental Health Leadership Alliance, and she's a psychiatrist who specializes in this particular area. And then to close us out would be Adrienne Griffin, the Executive Director of the Maternal Mental Health Leadership Alliance, and she'll put forth very specific policies that would be supportive and helpful to mothers and pregnant women, particularly during this time. As a reminder, the briefing is being recorded. Please submit your questions through the chat box. We have a dear colleague from March of Dimes who's moderating, who's capturing those, and we will handle them at the end. So without further ado, I'm going to turn this over to Dr. Kanika Harris. She is our first speaker today. She is a behavioral health scientist in the field of public health with a special focus on social determinants of health, health equity, and women's health. She is also a mother, doula, and birth justice advocate. Dr. Harris serves as the public health expert for the DC Mayor's Lactation Commission. She is also co-directing and producing a documentary called Listen to Me, which explores 4 women at the front lines of the Black maternal health struggle while walking the tightrope through pregnancy and motherhood. Dr. Harris will share her personal lived experience with pregnancy loss and maternal mental health conditions, the focus of today's congressional briefing. Dr. Harris?
Thank you. Good afternoon, everyone. Thank you so much for the introduction, Dr. Wright. I see inequity wherever it exists. Call it by name and work to eliminate it. I vow to create a better world. These are the words of Dr. Shalon Irving, who, as many of you know, passed away from postpartum complications and medical neglect in 2017. I'm sharing my story today in honor of Shalon's mission and the many women who are the fallen heroines of a flawed maternal health care system in the US. This is the first time I'm sharing my story out loud to myself, my husband, family, friends, and colleagues. While I ask for your grace, I do share my truth unapologetically. My postpartum depression went undiagnosed for years. It was something I suffered through silently. There was no space to stop, raise the white flag, and ask for help. To understand how I got to this point and to understand any Black mother's story in America, we must start from the beginning. Not when she finds out she's pregnant or is having thoughts of motherhood, but the intergenerational experiences that makes her who she is. I was raised by 3 generations of women that broke barriers of structural racism as first-time business owners, homeowners, and first-generation high school and college graduates. I watched the women in my family make miracles happen, endure and circumvent the daily assaults of racism, and grieve in silence. For many Black women, what I am saying is not unique. While there are nuances and variations that shape who we are and how we navigate the experiences of becoming Black mothers in America, we are all of this ilk. My first pregnancy was in 2010, while I was working as a full-time birth doula and completing my PhD program at Michigan. It was also a year after losing my mother to a rare heart condition. My mother was everything, my rock. I was very excited about pregnancy and the birth process after working as a doula for 4 years. I had never had a client that required an emergency C-section in all those years, and I was planning for a healthy vaginal birth like the ones I had witnessed. 5 months into my pregnancy, my midwife suspected I was carrying twins. She was right, and I had to switch to a high-risk OB practice. Just 2 days after a great follow-up appointment with the OB with no warning signs, I suffered an episode of HELP syndrome, a life-threatening condition characterized by a breakdown of red blood cells and liver failure. And I lost my twins, a boy and a girl, at 32 weeks from a placental abruption, when the placenta separates from the uterine wall too early. The EMTs that rolled me into the hospital with only minutes to save my life, when the EMTs rolled me into the hospital, I was stopped by the receptionist in the ER who asked for proof of insurance before they could take me back to surgery. I believe this stop robbed me of critical time needed to save my life and my children's life. I woke up 24 hours later in the ICU to news that my son was deceased next to me and my daughter would not make it. She died in my arms when we released her from life support. 3 days later, I was discharged. I felt I was being released too early and communicated that. With little follow-up when I got home, I was unsure of what to do when I started experiencing blurred vision. My eyesight has never fully recovered, and bad headaches. I reached out to a white friend who was a resident at the hospital where I delivered. When I told him my symptoms, he rushed to my house, took me back to the hospital, and demanded I get the care I needed. My blood pressure was so high that I was at a risk of suffering from a stroke at any moment. It still terrifies me to think what might have happened if I did not have the help of that friend. The next year was a blur. In addition to experiencing traumatic birth and trying to heal from a C-section and serious medical complication, I was also grieving the loss of my children and not having my mother by my side. My husband, sister, and a few close friends were very supportive, but I had a really hard time coping with that amount of grief. 2 years later, I did give birth to a healthy son, born at term. This time I had a doula. She knew about my past, provided essential support, and made sure my husband and I were well cared for. That support meant everything, and it made navigating the hospital after a traumatic experience manageable. My postpartum experience was very doable. I had the support of my aunt and was happy with my birth experience. 4 years after the birth of my son, the unthinkable happened. I became pregnant again with twins, another boy and girl. They were back. I was ecstatic and terrified all at the same time. Would I suffer the same trauma as before? Would I die this time? I did not tell many people I was pregnant with twins again. The first doctor I saw at my 10-week checkup was more concerned with teaching her medical student than focusing on my needs. My blood pressure was elevated at this visit, and she asked me to retell my trauma. She then told me, considering my past loss with twins, there was not much that could be done, and we only could hope that I'd make it to 20 weeks. My heart dropped at this news, and any joy I could hope to have in this pregnancy was taken from me. It was insensitive, it was cruel, and it was wrong. I immediately switched doctors, although that damage was done. But that pain also fueled me to prove her wrong. Everything I did from that point on was making sure my babies were born healthy. I switched providers, I did research, I found alternative ways to control my blood pressure, and was vigilant about nutrition, all things she said would not work. Subsequently, I never went on medication, and at 39 weeks, I gave birth to a healthy boy and girl. I did it. I got us all here. However, my delivery was another nightmare I could not believe I was reliving. This time, the chief resident anesthesiologist made 6 failed attempts at placing an epidural. I found myself screaming for her to stop, and she would talk over me, asking the attending physician for permission to try again. After sitting through what I now understand was abusive treatment without a support person, the hospital's policy did not allow a support person in the OR. I was ultimately given general anesthesia. Subsequently, I did not bond with my babies immediately. I left the hospital feeling violated and re-traumatized. I did not know that my traumatic hospital and birth experiences would put me at higher risk for postpartum depression. I also did not have a postpartum plan. Postpartum help and support for twins was expensive. I thought if we just made it all here safely, I could figure out the rest. Let's all just get here. That's all I had the capacity to do. I needed much more help than I realized. During my postpartum visit, I took a brief survey for postpartum depression. My answers did not signal a need for follow-up, and there was little discussion about warning signs, but I did need help. At home, my husband and I were crumbling under pressures from lack of sleep, work, and the tremendous responsibility of feeding and caring for 2 newborns and my 5-year-old son. I had extreme pain from the C-section and epidural injection site. My husband was concerned about my erratic behavior and emotional outbursts. And one day in the middle of the night, he took the babies from me and called for help from friends, but not medical professionals. As a family with excellent health insurance, advanced degrees and resources, and an affluent zip code, we knew those things would not mean anything to the healthcare system. Would reaching out for professional help trigger monitoring from Child Protective Services? Would they take my children from me? I had sometimes jokingly shared with my friends ideas of suicidal thoughts or of harming my babies. They responded, "We all have those thoughts sometimes. You are okay." I revealed to close friends that I thought I was suffering from postpartum depression. They said, "Maybe you are," but I was so highly functional because I had to be that no one really knew how bad things were. I did not know how to ask for help or what help I needed. Our good, expensive insurance also did not cover a provider that I could connect with culturally, someone who could see me for who I really am. I eventually found a woman of color in New Jersey who worked with me on a sliding scale out of pocket, recognizing that my income supported a family of 5. She has helped me not only work through my experiences, but also healing from grief and loss, managing the daily effects of microaggressions, and the challenges of mothering. And she's also coached me through how to bring more balance into my life and asking for help. What I want you to take away from all of this is that we need more comprehensive maternal care through the end of the postpartum period, especially during this pandemic. Theoretically, I had everything society said I needed, and it did nothing for me or Dr. Shalon Irving. We need postpartum care that addresses our birth experiences, especially for Black mothers who are more likely to experience trauma and suffer from postpartum depression. We need a continuum of care where every professional will see us and has a clear picture of our entire history, and they are also communicating with each other. Postpartum care and follow-up for mental health should be at least a year with insurance coverage. We need culturally relevant screenings for postpartum depression and other mood disorders for women of color. There are dire public health consequences for the United States if we ignore this maternal mental health crisis for all women. Black women are not broken, weak, genetically inferior, or deficient. We have been saving our own lives since we were brought to this country against our will. Racism is the only denominator that is killing us and keeping us from the quality of care and resources needed to thrive and survive. I thank you for your time and for listening to my story, and I thank the Maternal Mental Health Alliance for the opportunity to share. I'm turning it back over to Dr. Wright. Thank you so much.
It always takes a minute for me, and I've heard the story repeatedly, and it still takes my breath away. Thank you so much for sharing it and sharing it so boldly and with such grace. Thank you so much.
Thank you.
Okay, Dr. Rahul Gupta. Dr. Gupta is the Senior Vice President and Chief Medical Officer at the March of Dimes. Dr. Gupta provides strategic oversight for March of Dimes medical and public health efforts to improve the health of all moms and babies. Dr. Gupta was previously the Commissioner and State Health Officer in West Virginia, is an adjunct professor in the School of Public Health at West Virginia, and also holds several other academic appointments. Dr. Gupta is widely considered a national thought leader and a driver of good public policies on health issues critical to mothers, babies, and families. Dr. Gupta will be speaking about how the COVID-19 pandemic has affected pregnant women and new mothers, especially women of color and all women living in poverty. Dr. Gupta?
Thank you, Dr. Wright. And good afternoon and good morning to some, wherever you may be, and welcome to the program today here. I really want to thank Dr. Harris for bravely, once again, sharing her story. It is an important reminder to us why we do what we do every day.
Every day.
And a part of that, I just want to state some facts for you, which is first, virtually every measure of the health of pregnant women, new mothers, and infants living in the United States are trending in the wrong direction. For example, we have every 1 in 10 babies is born preterm in this country. And if you are a woman of color, your likelihood is 50% higher. Every 12 hours around the clock, we've talked about this, a woman dies as a complication of pregnancy or childbirth. And if you're a woman of color, it's 3 to 4 times more likely. And this was all happening before COVID-19. So the culmination of these challenges is leading and has led us to an urgent crisis that demands a comprehensive response by policymakers at every level of government. Just last week, on May 15th, CDC released data that suggests that although 1 in 8 women report symptoms of depression after giving birth, only 1 in 5, that's nearly 20%, that's 1 in 5 women were not asked about depression during a prenatal visit. So as healthcare providers, we're missing opportunities to screen women for depression and other mental health conditions. If left untreated, of course, the mother's health can cause issues such as difficulty in sleeping, eating, as well as behavioral problems for herself and her baby. So access to mental health care is critical to the overall health of both mothers and newborns. And this pandemic has created significant stress and anxiety for pregnant women and new mothers who have now a number of worries in addition about their fetus, newborn, and delivery experiences. In the current climate, it could even be more difficult to access appropriate mental health care. While much remains unknown about the COVID-19 pandemic and its effects, pregnant women have clearly been historically at greater risk of severe morbidity and mortality from other respiratory viruses from the same family. As such, pregnant women should be considered an at-risk population, as well as postpartum women and their infants following their stay in hospitals or birthing centers. And one of the reasons for it is that we have more pregnant women today that have complications because of their general health conditions. We also know that women of color and women who live in poverty each often face more severe birth outcomes than those of their white peers. We must factor that in. For mothers, we know that, as I mentioned, there are so many challenges that come, including access to healthcare, social, economic, and environmental factors, and structural racism. These issues do not go away and have not gone away during the coronavirus or COVID pandemic. In fact, we have data to account that it's making it worse. Unfortunately, not all states are uniformly reporting that data, that demographic data. But we know from states and jurisdictions that have, that it's having a disproportionate impact for some community of color. For example, we know that based on available data, people of color account for 28% of confirmed cases with known race or ethnicity, despite that there's less than half of the total population as of May 5th. So we know that race and ethnicity is missing or unspecified for nearly 2/3 of the CDC's reported cases. We're just not capturing it. In the majority of states reporting data, we know that African-American people account for a higher share of confirmed cases in 20 of the 31 states and deaths in 19 of the 24 states compared to the share of total population. It's important that we need to account for all of the population and capture all of this data. What can we do about it now? We can start by improving this data collection. States are not only broadly not collecting that data on pregnancy status or demographics, which means that we don't know a lot about the impact of COVID on pregnant women, and we don't know even less about the impact of COVID on mothers of color. CDC must work with states to ensure that they're collecting data to inform care and public health activities. We also think that Congress should immediately provide adequate funding, and we can talk about this more in detail, to CDC to reinvigorate and improve the Emerging Threats to Moms and Babies initiative to provide real-time clinical and survey data on the impact of COVID-19 on pregnant women and their babies. Further, Congress must sustain this level of funding beyond the current crisis. We cannot go from crisis to crisis. We must develop a national infrastructure so we can quickly identify and respond to these threats, because the populations that are most vulnerable are impacted the worst. Beyond CDC, we also believe that actions must be taken to ensure pregnant and postpartum women are prioritized in research taking place at NIH. Currently, these populations and women of color and lactating women are excluded oftentimes from clinical trials for therapeutic and vaccines. In fact, we should be including these populations so they're some of the first ones to receive the vaccine and treatments, not the last. Furthermore, we also think that there are certainly registries that are existing today that need to be supported so we can understand better how it's impacting all people, especially women of color who are pregnant today. There's a lot that is going on in mental health, and some of my colleagues will talk more about it, but I think it's very important to understand that when physical distance is occurring, social and societal limitations are occurring, that women who are pregnant, and especially communities of color, are having an undesired and disproportionate impact. And therefore, it's important, on one hand, as a physician, I can tell you, for folks to be able to do what they can, find they're happy, do what makes sense to stay happy and connected in this time. But on the other hand, it's important for us to make sure that we are enacting the right policies, including ensuring that HRSA screening and tests for maternal depression-related disorders treatment program gets funded in the next CARE supplemental. Currently, this program is funded at only $5 million, and that needs to help. We also think that there's a number of provisions that can help support, especially pregnant women, but especially also women of color that are going through pregnancy and postpartum care at this time. So thank you. We look forward to your questions.
Thank you, Dr. Gupta. Appreciate your thoughts and your comments. And we know the March of Dimes is a leader in terms of producing and supporting healthy pregnancy outcomes. So your message is particularly vital today, and we appreciate it. And also thank you for specific recommendations about what can be done and recognizing the importance of different experiences with our systems, particularly in COVID-19 right now. It's very, very critical that we address these differences now. So thank you very much. Okay, our next speaker is my colleague from the Board of Directors with the Maternal Mental Health Leadership Alliance, Dr. Pooja Lakshmi. She is a clinical assistant professor of psychiatry at George Washington University. Dr. Lakshmi is a reproductive psychiatrist specializing in treating women during the childbearing years. She's a faculty supervisor at the 5 trimesters perinatal psychiatry clinic at George Washington University, and also maintains a private practice in Washington, D.C., where she's active in maternal mental health advocacy work and community building. Dr. Lakshmi's articles about motherhood and mental health have been featured even, I think, 2 weeks ago in the New York Times. Dr. Lakshmi will speak about her clinical experience with women in COVID-19 and will offer expert guidance for managing stress and anxiety during the pandemic. Dr. Lakshmi?
Thank you so much, Dr. Wright, for that lovely introduction. And I just want to say that it's really a pleasure to be here with you all this afternoon, talking about a topic that all of us are so passionate about. I want to also thank Dr. Harris for so candidly sharing her story. You know, I think it's one thing when we read about these stories, but to actually hear the full narrative of what another woman went through, you know, I felt nauseous at various points of it. And I think it's really powerful to hear it coming from the source. So thank you, Dr. Harris, for being willing to reveal that about yourself. And yeah, it's why we're all here. I was speaking with a colleague last week who shared with me a case, actually, or a woman in the Washington, D.C. area who also had a heartbreaking story during COVID. She delivered at a hospital here in D.C. and her husband ended up testing positive for COVID. This was in the very beginning of the pandemic in March, before hospitals really had protocols in place. So he was still allowed to be in the delivery, even though he was not feeling well. And the baby was born with significant medical complications, and so was in the NICU for 2 weeks, and mom was not allowed to be with the baby for those 2 weeks. And then even when they did bring the baby home, they still needed to social distance. So I think it was like 3 weeks until she saw her baby or was able to hold her baby, which is just heartbreaking. And, you know, we're hearing stories like this everywhere. You know, I don't think it's specific to Washington, D.C. I think it's happening all over the country. And while I understand that from a medical standpoint, this is a virus that we still don't understand very much about, so medical providers are really wanting to be cautious and protect patients and families and also protect themselves. But the mental health repercussions of these medical decisions are really powerful. So we have to kind of keep that in mind. So I wanted to talk a little bit today about what I'm seeing in my own clinical practice as a perinatal psychiatrist. So I work with women who are pregnant and postpartum and dealing with things like postpartum depression, postpartum anxiety. And like Dr. Gupta said, this is not a new issue. You know, this was a crisis even before COVID-19 came around. So for those of us in the field, it is sort of like, okay, things are clearly much worse right now, but we've been struggling with this for a while. I am seeing a significant increase in anxiety in particular. So obsessions, compulsions in women who had not previously had those types of symptoms, a lot of intrusive, graphic, obsessive and kind of anxious images as well around upcoming deliveries and what could happen. A lot of catastrophizing for my patients that are going to be delivering this summer or even in the fall. And the thing with that type of anxiety is there's really nothing that you can do. So much of this is out of your control as a mom and as a woman. So that's what makes it particularly difficult. And then on top of that, a lot of insomnia, trouble sleeping, which can be a symptom of anxiety and depression. And then because of the social isolation, these feelings of loneliness and turning into even hopelessness and meaninglessness as well. So those are some of the clinical symptoms that I'm seeing in my practice. And actually just last week, 2 new research papers came out pretty much confirming what those of us working in the field have been seeing for the past 3 months. Now, both of these papers have not yet been peer reviewed. They're still in preprint, but they're out of Canada, one from the University of Calgary that surveyed 2,000 women, and they found that 40%, almost 40% of the women that they surveyed had clinically relevant symptoms of depression. These were pregnant women. 40% of them had clinically relevant symptoms of depression. And then almost 60% had clinically relevant symptoms of anxiety. These were pregnant women. And then a whopping 70% had pregnancy-related anxiety. And now that's what I was talking about that I'm seeing really just huge amounts of in my own practice. When we say pregnancy-related anxiety, we mean fears around safety for yourself and safety for your baby when you deliver. So these fears around, what if I'm going to be in labor and I can't have my support person there with me? Or what if I need to wear a mask when I'm laboring? How am I going to be able to do that? What if I'm one of the 15% of women that test positive, that's asymptomatic and test positive for COVID, and then I have to be separated from my infant? And then even if you make it through, delivery, what am I going to do at home when I don't have any support and I might have another young child at home? How am I going to handle taking care of these small kids by myself? So all of that is what we kind of categorize as pregnancy-related anxiety. Another interesting piece of this particular study is they went in and they looked at what were the stressors or concerns that then were the biggest predictors of developing clinically relevant symptoms. And the biggest predictor was social isolation. So the more that the woman perceived to be socially isolated, the more her chances were of having clinically relevant symptoms of depression or anxiety. A second study out of the University of Manitoba looked at about 600 women, and these women were postpartum and then even up to having kids up to age 8. So it was a little bit of a different demographic, and they found similar rates, around 30–40% of clinically relevant depression, anxiety. One piece though with these studies that we need to keep in mind is that the groups that they looked at were primarily Caucasian, and they also were high income. So they were not able to identify a lot of what we talked about today. And I would imagine that women of color and women who are living in poverty, the rates are going to be even higher. So I think that there's, this research is really dramatic, and it just points to the fact that what's going on right now is a crisis, and it's going to continue. As long as COVID is with us, things are going to be this way. So it's really important for us to take action and actually find solutions. I'm seeing this pan out in the community as well. I co-founded a Facebook group with 2 of my physician colleagues. It's called COVID-19 Maternal Wellbeing, and we have almost 5,500 members now. And I'm seeing a lot of grief around not being able to have the expected pregnancy plan, not having the prenatal visits that you were going to have, having everything be through televisits now, not getting as many ultrasounds, so not enough chance to really connect with the fetus and feel secure in the fact that your baby, the fetus is developing, and then grief around even things like not being able to have a baby shower. That things like that have a psychological impact because it's part of bonding with your baby. Each of these little milestones as you go along in pregnancy is hugely symbolic, and it means something for mom as you're transitioning into this new identity as a mother. And for women that are pregnant right now, they're being robbed of that. you know, there's ways that people are working around it, and I'm seeing lots of amazing videos on social media and things like that, which is great, but it's not the same thing. And then, like we talked about, the grief around not having a delivery experience that was what you expected, and all the fear that comes up there. The other new thing that I'm seeing more recently is with states loosening some of the guidelines and things opening up again, moms just really worried about how to make these decisions, because there really aren't medical guidelines. A lot of these decisions are things that families are having to make on their own. You know, is it safe for my kid to go back to daycare now? You know, what if a family member who is elderly is really the only person that can be there to help take care of my baby? So it's sort of like these different difficult decisions that every family is having to make, but moms are really the ones that are bearing the weight and the burden of this mental load of having to make these decisions, and that's really wearing on women. So I wanted to share also a little bit about some strategies that I know some of you on this call today are clinicians. And so I thought it would be helpful to share some strategies that you can use with your own clients or patients that might be pregnant or postpartum right now to help support their mental health. The first thing that I would say is limiting media intake and making sure that the sources that you're consuming are good sources. So, you know, the CDC, our MMHLA website has some great resources, Postpartum Support International, but also, you know, we really need to make sure that we're setting limits on the amount of information that we're taking in, because constantly scrolling social media or kind of watching the news just serves to increase anxiety. So I would advise folks to counsel their patients about that. The second thing is to remember that it's okay to feel grief right now. You know, because COVID is such a, you know, we're living in a pandemic, people are dying. It's a really scary and horrifying time. So some of my patients are saying to me, you know, well, I feel bad about the fact that I'm angry that I haven't had a baby shower. And it's sort of like, well, no, actually you can feel bad about that. It's okay to feel bad about that because these are losses, even though it's not something that, you know, is impacting your family's safety. These little losses that everyone's experiencing right now are still really important to grieve and to process. So allowing yourself to have those feelings. And when they come up, recognizing that grief comes in waves. It's not a linear process. So it's going to be the type of thing where, you know, one minute you might be fine and the next minute you might be feeling really sad. And I tell my patients that when they're feeling big feelings, the thing to do is either to connect or to reflect. So connect with somebody in your life who's non-judgmental, that you can pick up the phone and call and you know that they'll be there to support you, or reflect, journal, write out some of those feelings, get those thoughts out of your mind, something else that's really helpful. The other thing for pregnant women in particular right now is find places in your life where you do have agency and control, because there's so much that is out of our control, but there are places where you can take action. So find out what your hospital policies are. Call your OBGYN's office and ask them, you know, what is the plan? Like, you know, am I allowed to have a support person? If not, if it needs to be virtual, do I need to bring my own device? You know, get into the nitty gritty. The March of Dimes has a great birth plan on their website that hopefully we can link that, and they've updated it for COVID. So they run through all of these specific questions that you can ask your medical providers around how their policies have changed right now during COVID. So that's a place where you can actually take agency and take some action. And then finally, make sure to stay connected with family members, doing it virtually. Our Facebook group, COVID-19 Maternal Wellbeing, is a really great place for support and also for evidence-based information. So hopefully we can link that too. And then finally, I'll just say, in terms of clinical resources, Postpartum Support International is just a huge, has such a wide range of resources all over the country. So many, I know a couple of you on the call right now are from Postpartum Support International. So as you probably know, they have chapters in every single state with volunteers who can help connect you with referrals for specialists in maternal mental health in your state. Also, Postpartum Support International has expanded their online support meetings. So they have specific meetings now for moms who have babies in the NICU or military moms, or I think they even have one for dads as well. So check that out on their website. And they also do have a helpline for providers where you can get a free consultation with a reproductive psychiatrist if your provider needs some help figuring out how to prescribe medications. So that's a place where you can certainly get support right now. So thank you so much, everybody. And I'm happy to take questions once we finish up too.
Thank you so much, Dr. Lakshmi, for your insightful comments and very specific tactics and approaches that both clinicians as well as pregnant women and or new moms can employ to help manage during this particularly difficult time. So thank you very much. And finally, we have our Executive Director of the Maternal Mental Health Leadership Alliance, Adrienne Griffin. Adrienne has spent the last 15 years as an advocate for maternal mental health issues following her own personal experience with postpartum depression and anxiety. She is the founding executive director of Postpartum Support Virginia, where she built programs to provide support to new mothers, train mental health providers, and create community coalitions to address maternal mental health. Adrienne will share specific policy initiatives to address maternal mental health, as we've been discussing throughout the last hour.
Thank you,
Adrienne. Mm-hmm.
Thank you, Dr. Wright, and to all of our presenters today, and specifically to the March of Dimes and our other co-sponsors for helping out with today's event. Dr. Harris, thank you for sharing your heart-wrenching story. It breaks my heart to hear that women still are treated like this. And that is why we all do the important work that we do. Thank you all for being with us this afternoon. We have over 400 people participating in today's briefing, underscoring how timely and relevant this topic is today. So if you've heard many times today, anxiety and depression are the most common complications of pregnancy and childbirth, affecting 1 in 5 new mothers. And this was before the pandemic. I want to also point out that complications from mental health issues are the leading cause of death for women in the first year following pregnancy. And 100% of these deaths from suicide and overdose are deemed preventable. For far too long, our medical system has separated the brain from the body. It's time we include mental health in healthcare. In fact, there is no health without mental health. And this is particularly for childbearing women. There's absolutely no reason that their mental health is ignored. Women are captive in the healthcare system during pregnancy and the first year postpartum. In fact, they will interact with a healthcare provider on average 25 times from conception to baby's first birthday, offering ample opportunity to engage with them on the topic of mental health. Moreover, maternal mental health conditions are relatively easy to diagnose and treat. Virtually all women who experience anxiety and depression during pregnancy or in the postpartum period can recover and lead normal, productive lives. The vision of the Maternal Mental Health Leadership Alliance is that all childbearing women will be educated about and screened for maternal mental health conditions and have access to high-quality mental health care. So in pursuit of that goal, and on behalf of our sister organizations, Postpartum Support International and 2020 Mom, we want to advocate for some specific policy items. 2 of the 4 that I'm going to discuss next focus specifically on maternal mental health, and then 2 address COVID-19 in particular. So first and foremost, we need to extend Medicaid coverage for all new mothers for a full year postpartum. Medicaid currently covers 50% of the births in our country, providing women care during pregnancy, labor and delivery, and in the postpartum timeframe. However, in many states, women are at risk of losing their Medicaid coverage at 60 days postpartum, leaving tens of thousands of new mothers uninsured at a medically vulnerable time in their lives. Women in the South are the most likely to be impacted. And in Texas, for example, new mothers risk losing their Medicaid coverage at 60 days postpartum if their annual income exceeds 17% of the federal poverty level, or a total of $3,692. That's their annual income. A few statistics will help underscore why it is vital to maintain a new mother's insurance coverage. Nearly 25% of maternal deaths occur 6 weeks after postpartum. The peak onset of postpartum depression is 3 to 6 months postpartum. And the peak incidence for self-harm, which as I said earlier, is one of the leading causes of death, is 9 to 12 months postpartum. This is well past the time that many women have lost their Medicaid coverage. So for all of these reasons, we strongly advocate for extending Medicaid coverage for all new mothers who are eligible for a full year postpartum. Secondly, we encourage Congress to increase funding for state maternal mental health programs. In 2016, Congress passed the Bringing Postpartum Depression Out of the Shadows Act. This landmark legislation provided first ever funding for states to create programs to address maternal mental health. In the first year of the program, 30 states applied for funding. But because funding was just limited to $5 million, only 7 states were funded, representing just 10% of births in the United States. These state programs are extremely cost effective. In fact, the Massachusetts program, which is the flagship program, costs just $8.33 per year per mother. In contrast, as Jamie pointed out earlier, the cost of not treating maternal mental health issues is a staggering $14.2 billion with a B each year in lost wages and productivity of the mother and addressing poor health outcomes of the mother and the baby. To ensure that all new mothers receive the same level and quality of care, we ask that Congress provide additional funding for states to create these important programs to address maternal mental health. And now 2 particular topics specifically related to COVID-19. All women should be represented in COVID-19 research and drug trials. As we've heard from Dr. Gupta and Dr. Lakshmi, new mothers and mothers-to-be are experiencing significant stress and anxiety during the pandemic, opening up Pandora's box of worry. Should I become pregnant? If I am pregnant, how will coronavirus affect me or my baby? Will I be able to have a support person with me in the hospital? If I have COVID-19, will I be separated from my baby after he or she is born? How will I care for my baby? And on and on and on. These concerns undoubtedly will remain until there is better understanding of how the coronavirus impacts pregnant women, their unborn babies, and their newborn infants. And as we have heard, women of color and women who live in poverty are disproportionately affected by both mental health issues and the coronavirus. Therefore, we advocate for expanding COVID-19 research to include women who are typically excluded from this type of research and clinical trials, namely women who are pregnant or are breastfeeding, women of color, and women who live in poverty. And finally, we encourage Congress to support a robust COVID-19 stimulus package that supports mental health care. The rates of mental health issues have skyrocketed during the pandemic. According to the Kaiser Family Foundation, almost 50% of Americans report their mental health has been negatively impacted due to worry and stress about the virus. And Postpartum Support International reports that the number of women participating in online support groups has quadrupled from February to April. Thus, we implore Congress to pass a COVID-19 stimulus package that focuses on providing robust resources for mental health and to shore up our nation's behavioral health system. We can no longer delay, deny, or dismiss addressing maternal mental health complications, particularly in light of the pandemic. All mothers in the United States, regardless of where they live, how much they earn, or the color of their skin, deserve to be educated about and screened for mental health issues and have access to high quality, appropriate mental health care should they need it. An investment in the mother's mental health is not only an investment in the mother, it's also an investment in the child, the family, and society at large. According to Sheila Kitzinger, a noted activist and author about pregnancy and childbirth, quote, "The way a woman gives birth and the kind of care given to her and her baby points to the key values of the culture," unquote. It is high time we valued new mothers in our country. Thank you very much.
Thank you, Adrienne, for putting forth actionable items that our nation's elected officials can do to better support the mental health and well-being of new mothers in our country. We appreciate that very much. It's very concrete and very action-oriented, and we can do this as a country, as a society, we can do this. So we only have about 5 minutes left, and we have about 4 themes that have been captured by our colleagues at the March of Dimes. So we're gonna have to do this very quickly. Number 1 is, how do moms advocate for themselves, or how can we advocate for them so providers stop dismissing moms and their concerns? Who would like to speak to that?
If I may speak to that, you know, I come to this conversation as an advocate, as a mom who was dismissed with a 3-month miscarriage and then dismissed with both of my children, saying that that I could just take some Zoloft and go away and be fine. So from the advocacy position, and again, I'm speaking as a white woman in the suburbs of Boston. So there's several unique situations with that, but utilize organizations like the March of Dimes, like the Maternal Mental Health Leadership Alliance. Everyone on this call today has total solidarity with every single one of us here. Bring those causes and concerns to us. I also want to say hello to my state senator, Joan Lovely, who's on this phone call. She's the chairwoman for the Postpartum Commission and the Commonwealth. Seek out who your state reps are, who your state senators are, who your city councilors are, who your federal representatives are, who your federal senators are. Use the noise. Right now, maternal mortality has been exacerbated during this pandemic, as well as mental health. I get multitude of Google alerts in my inbox all day long about the current state of affairs, because again, we can't get testing, we can't get PPE, and we can't take care of our mothers. So use organizations like us, use your elected state representatives, and use your voice. Use Twitter, Instagram, Facebook. You have an incredible community as mom advocates to do this. I think listening to Dr. Harris's story is another thing too. And Dr. Harris, maybe you have a few words of your own as you advocate for your family.
You're on mute. You're on mute.
Sorry, I was unmuting myself.
Thank you.
I would say that when you're in the hospital or you're in these situations at the moment, you have to find that social worker in the hospital, that ombudsman in the hospital, whoever the attending. You have to find that person. I didn't get to go into my story, unfortunately, about the angels in the hospital that did advocate for me. And those always do exist. And once you find that person, you know, ask them for help, ask them what the next step is. But you do have rights in a hospital. You do have rights. Know your legal rights before you go to the hospital. Know who to talk to, know who that attending is when you're giving birth. All those things will kind of lead you to some answers sooner than later. And those organizations are great. The organizations Dr. Lakshmi brought up that I didn't know about, and it's important that we know about. Those are really important. And to keep searching for those people in the healthcare system that will advocate for you, because they do exist. I did have some angels that stood up for me and that did help me.
I also
Sorry,
wanted to jump in too, is that okay? Another place of support can be the Facebook group that we have. What I'm seeing is people posting, you know, I'm in New Jersey and I'm delivering at such and such hospital, and then people responding and saying what their experiences are and sharing the protocols and things like that. So I would definitely recommend joining social media, you know, groups and things like that, where you can speak to other moms who had delivered in the same place.
Okay, thank you. Another theme that we have is, how do we combat racism and bias that exists in the healthcare sector, especially now that we have the added challenge of COVID limiting who can be with a woman in labor and delivery? That's like a 5-part question, but let's see what we can do with it. How do we combat racism and bias that exists in the healthcare sector, especially now with COVID-19, where we're not allowed to bring people into the L&D who can be advocates, who can support her? Any thoughts on that?
So as you said, that is a huge question. We could each write a thesis about that. That really has been the heart of what we've been talking about today. I think it's just really, really important just in the last few seconds that we have today to remember each and every one of us is responsible for raising our voices about this issue. On behalf of yourself, on behalf of someone else, we can no longer go silently on these issues of maternal mental health, in particular for those who are most impacted. So we all just need to keep chipping away at it, one voice at a time.
And you know,
Dr. Harris wants to say, go ahead, Dr. Gupta, and then Dr. Harris would like to close us out.
I think in a very difficult situations and complex questions, you have to ask the reverse. You have to ask, what's one way that we can continue this to allow this to happen and so no one would know? I'll tell you one way that we're doing right now, which is not know where these things are happening because we're not keeping an eye on the data. So if we continue the way the path we're on, because we will not identify where these things are happening, where they're not happening, we're not going to be able to, first of all, gauge it, understand it, or do anything about it. So that whatever we do will be spotty, it will be anecdotal, it will not be systematic and structurally changed. To do that, we need to understand it better. And we could not have developed a better system if we wanted to continue to promote the racism and the bias in the healthcare system. We have done that actually. Now we need to undo it by creating a very transparent data capture system that can actually figure that out and capture it so we can then work towards it to fix it.
Thank you, Dr. Gupta. Absolutely. And Kanika, you have the last say on this. You kicked us off and now you'll have the last say on this.
Okay, I just wanted to address that question. Of course, the whole maternal health care system needs restructuring, number one, and that's how this is just a really tough question to answer. I will also say for people who are looking for resources right now, I have seen on the Black Mamas Matter website that they do have resources about how to navigate these issues for Black mothers that are dealing with COVID. They have specific plans in place that you can look at, particularly to this issue for women of color. And we just have to keep calling these stories out. In addition to what Dr. Gupta is saying about the data, that is very important, but these stories, we have to keep calling them out. We have to keep naming this stuff so that we can eliminate it. Thanks so much.
Thank you. And I'd like to thank all of our panelists today for an incredible job putting the issue out there, as well as strategies, approaches to remedy what we've heard. I'd also like to re-thank our sponsors. We could not have done this without you, and the special technical assistance that we were able to receive from the March of Dimes. Thank you so much. And I'd like to remind you to please go to the MMHLA website, where you can find a summary of what's happened today, the notes, as well as a number of additional pieces of information and links to additional pieces of information. So thank you very much. And I'll turn it back to Adrian. You might have something to say as our executive director.
So again, thank you, Dr. Wright, for doing a terrific job moderating, to all of our panelists, our sponsors, and we will also be pushing out an email to everyone who participated today with a link to the webinar, as well as the link to our website, where we'll include all of the information that was discussed today. So thank you very much, and this concludes our briefing today.
Thank you.